Hello and welcome to EHA Unplugged. Today we have Professor Chiara Bonini here with us. Professor Bonini is from the University of San Raffaele in Milan, Italy. Her research focus is on the development and validation of cell and gene therapy in cancer. So to start, Professor Bonini, can you give us an overview on the rate of relapse after long-term CAR T cell treatment in hematology? Are there differences between the diseases or between different CAR T cell products?
The rate of relapse after CAR T cells really depends on the disease that we're treating. Even when the same CAR T cell product is used for different diseases, we have rates of relapses which are really different. Rates of responses which are different. For example, the rate of response in ALL, acute lymphoblastic leukemia, is higher than for lymphoma, but then the rate of relapses is also higher in ALL than in lymphoma. And then, of course, it's different also with different CAR T cell products. Myeloma, which is treated with a CAR T cell specific for BCMA, with the registered products at least, has a rate and also duration of possible relapses, which is longer compared to other diseases. So we can't really find a magic number. It's really different for different diseases.
Talking about relapse, what are the main mechanisms of relapse?
The mechanism of relapse, the reason why a disease relapses after CAR T cells, it's a matter of strong investigation at the moment. A very interesting and important question to answer, to identify a new treatment, new regimen, and make it work better. There are a number of reasons. First reason, the first that we have identified in some way, pretty common in ALL, is the loss of the antigen, the loss of the target. The CAR T cells attack the cancer cells because it sees a specific target, a specific molecule. CAR T cells against CD19 see CD19. So we might have a loss of CD19, which has different mechanisms. It can be not just a loss, but a modification of the protein, so that the exact part of CD19 that is recognized by CAR T cells is hidden or is not present anymore. It can be a complete change of the transcriptional profile of the cancer cells that will not need to express CD19 anymore. But at the end, the mechanism is the loss. The cancer cells becomes invisible. And in that case, we will definitely need to use another target, possibly to use more than one target at one in a single step, targeting CD19 and CD22 together, for example, so that we will reduce the possibility of the cancer cells to lose both molecules in the same cells at the same time and become resistant. So this is one of the reasons. A second class, let's say, of evasion mechanism rely on the CAR T cell product themselves, not really on the cancer cells, and it's related to, in a way, the unique aspect of CAR T cells, of T cell therapy, which is the fact that we are producing the drugs all the time in a personalized way for every patient. So we start from patient samples of blood, his own lymphocytes in the majority of cases. We modify to introduce our CAR and then have a product ready. So these CAR T cells are different. The drug is not always identical in every patient. And this also depends on the fact that every patient has his history, has his age, his hormonal status, his gender and age combined, his disease, his history of disease, his treatments before CAR T cells. All these aspects can impact on the quality of the starting material, the lymphocytes from the patient, and have an impact then on the ability of the CAR T cells to be fit, what we simplistically nominate as a fit CAR T cells, which is a cell able to engraft, to expand, to kill, to differentiate, to home in the proper places, and to remain as a memory cells able to do exactly the same work if it's needed. So this is very different in every patient, and in some cases we see CAR T cells disappearing very early, and then we have to be careful because their activity may not have been complete, and so we might lose the effect. These, I would say, are the two main reasons, especially at least in liquid tumors, which are the tumors that we treat today. In solid tumors, we might end up with other mechanisms, and at this meeting we've heard a lot on the hurdles that we have to face for making CAR T cells work also in solid tumors. It's nice that we start identifying these hurdles, because that means that we can find ways to overcome them. Just to mention one is the difficulty of the CAR T cells to traffic inside a solid mass, which is of course more difficult to be populated by CAR T cells than liquid tumors. Or another is related to the what we call the immunosuppressive tumor microenvironment. You have to think that the cancer cells are not alone. They are sort of directors of an orchestra in which all the cells around them end up playing the music that the cancer cells wants. And in this music, there is also the ability to exhaust or kill in some way or eliminate the T lymphocytes, which could kill the cancer cells, and also the CAR T cells. So we have to know, to study, to investigate, so that we can make the CAR T cells more active.
So you've mentioned the possibility of having a specific CAR T to manage some diseases. Are there any recent developments in CAR T that are particularly promising?
Well, I think that one of the, let's say, many new approaches are under development now and will be developed by the addition to the CAR T cell field of the genome editing platform, which means that we can not only add the CAR to the T cells, which is essentially what we're doing today. No? We use viral vectors, or in some cases non-viral vectors, but anyway, vectors that are able to introduce a gene in lymphocytes, and we introduce the gene for CAR, so that we express the CAR. So to this technological platform, we can add the genome editing platform, which is the, let's say, the CRISPR platform today, which is a technology that allows us not only to add a gene, but also to destroy a gene. For example, imagine that in a specific tumor, we learn that the tumor is able to exhaust the CAR T cells because of the interaction between a molecule present in the CAR and a molecule present in the CAR T cells. What if we destroy that molecule in the CAR T cells? CAR T cells can become able to resist to this suppressive mechanism. So this is only one of the examples, but the number of possibilities is really wide, and many investigators are combining all these tools to generate new CAR T cells. I think that will be an important new frontier.
So for patients that relapsed after CAR T treatment, can they still be treated? Is a second infusion of CAR T possible?
A patient who relapses after CAR T cells has different options. First of all, she has the option of standard of care treatment, so any other approaches that we have, and in some cases they can work after CAR T cells, and maybe were not available, could not be used in that patient before. So I'm talking about chemotherapeutic agents, the transplantation setting, the transplantation procedure, the small molecules, antibodies, BiTEs, all these is an option. Then there is also the option of second infusion of CAR T cells. Why should we give a second infusion of CAR T cell to a patient? We should give it because we know, for example, by studying, monitoring the patient after the treatment, then the reason of this relapse was related to the CAR T cell product and not to the fact that the cancer cells has lost the antigen. So by monitoring and studying everything that is happening in a patient treated by CAR T cells, we'll have the proper instruction on how to proceed with the next therapy, including a CAR T cell second infusion.
So, when CAR T was introduced, it was introduced as a one-time treatment. Does this still stand?
One-type treatment. That is a very nice question for me, because I really strongly believe in immunological memory. So I've been active in studying how to preserve the ability of T lymphocytes to persist for years, virtually for the entire life of a subject, even though we are manipulating their genome in the lab to create a therapeutic product. It is not easy. For sure, we have learned how to activate the cells, from which type of T lymphocytes to start, which cytokine to use to help them becoming memory cells and not really terminally differentiated effectors which have a short lifespan in front of them. So in some way, by using this information and implementing this information in the manufacturing, I think we can improve the duration of CAR T cells. On the other hand, a CAR is a chimeric molecule. Now, CAR stands for chimeric antigen receptor. This is a molecule that doesn't exist in nature. So the signal that it provides to T cells, even though we have designed the CAR to make it as natural as possible, it's not really identical to the signal that usually a T cells receives to get activated. And these signals are not just used by the T cells to get activated and kill the cancer cells, but they're also survival signals. So in some way, the duration, the persistence of CAR T cells might still be suboptimal, because we're not as good as we would like to be in copying nature. But knowing this, we can play with the pieces of CARs and try to make it better. So was it okay? Was it clear?
Thank you so much. It's great.